This is the case of a 62-year-old patient with angle closure glaucoma, who initially arrived after an Ahmed valve implant 10 weeks previously in her left eye. She complained of a significant decreased visual acuity for 4 weeks. The anterior chamber angle was closed and the posterior trabecular meshwork could not be seen in the primary position with or without indentation. Contact between the iris and the corneal endothelium was present in 4 quadrants. A grade 2 cataract was diagnosed and therefore the patient was scheduled for phacoemulsification cataract surgery. Due to an extremely narrow anterior chamber, we used the 1 mm blade to make the first approach through the cornea, and then, after filling the anterior chamber with dispersive viscoelastic material, we used the 2.4 mm blade for the main incision. A small pupil persisted, despite our initial efforts to enlarge it through viscomydriasis and marginal pupil sphincterotomies with Vanna's microscissors. Therefore, we opted for the placement of iris retractors. The iris retractors have been available for a long time now and can be used in cases of a small pupil to enlarge it and as a result to be able to perform a cataract phacoemulsification safely. One of the disadvantages of iris retractors is that more paracenteses have to be made. Most people prefer a diamond configuration rather than a rhomboid configuration because it provides a better visualization inferiorly, where most of the movements will be taking place. With a better visualization, now we can proceed to perform a continuous capsulorhexis using a trypan blue staining for an enhanced ability to see the anterior capsule. In this case, I used acetone for initializing the capsulorhexis, starting to the right center with Ninil and continuing with the Utrata forceps. Then proceed to the hydrodelineation and rotation of the nucleus. While introducing the handpiece for the nucleus phacoemulsification, it became apparent that the valve tube was indeed posterior to the iris, with significant adjacent fibrosis, which interfered with the projected stop and chop phacoemulsification technique. At this point, I had two choices. First, to continue with the stop and chop phacoemulsification technique, avoiding the tube, or second, to relocate the valve tube to have a better visualization for the rest of the surgery. I proceed with a routine phacoemulsification technique, grabbing the chopped nucleus to the center zone, a safer zone, until the last pieces of the nucleus were emulsified, trying at all times to avoid the tube in the inferior area. We continued with the removal of the cortical material and the filling of the capsular bag with cohesive viscoelastic material in order to place an hydrophobic aspheric single-piece intraocular lens in the capsular bag. As a final point, we cut the length of the valve tube with the protection of the IOL behind it and retrieving the iris retractors, concluding with a nylon 10 suture at the main width, finishing in that way the surgical procedure.